Okay, we can also apply heat and cold depending on what the mom's choice is. Some women like to have something hot put on them, on their forehead or on their body, a warm blanket or something. Some women like to have a cold cloth put on their forehead or something like that. This is something that is really what the patient would want. You can use hypnosis. I'm not sure how effective this is, but I heard that it can draw attention outside to external environment, and it just kind of helps her to focus in. So it decreases the awareness of the external environment, and it just really kind of helps her focus inward. These sterile water injections are done by midwives, and you can just put in some sterile water to numb these location points right here. And what's great about it is it has no effect on the baby. It can be as repeated as often as possible as well. And then biofeedback. This is moms. This is something that they'd have to be trained in before they went into labor, and to really just kind of be able to refocus and change their mental processes. For a posterior baby, they can do what's a double hip squeeze, and that's what this video is here. And there's a video I posted on counter pressure as well, or you can push upward on the knees to get that baby off of the coccyx. Both of these work really well to reduce the pain and pressure, and really good, especially if it's a posterior baby. And here is that natural water birth that I posted. You can watch and just see what that's like. All right, let's talk about pharmacological measures now. So we can use opioids, either IV or IM. These are the different ones that we can choose from. Cervix must be dilated, though, because this will cause the labor progress to be slowed. It can cause problems to baby and mom, respiratory depression on mom and baby, nausea and vomiting, drowsiness. So we usually use that along with antiemetics, such as these. We can do regional analgesia. Now this is just provides pain relief, no numbing. So it's an injection. We can put it into the epidural intrathecal spaces. I'll explain what those are in a minute, but it's surrounding the spinal cord to just have pain relief, but they're still able to sense the contractions and bear down. This is a really great option for women that want to still feel baby coming down and being able to push and feel the pushing sensation. And then regional blocks are the anesthesia. So if a woman is unmedicated and there's lots of stretching, we feel like she's going to tear, then we can do what's called a pudendal block. And it's right here in that pudendal nerve. And it just provides numbness around this region here. We give it if there's going to be any sorts of trauma, episiotomies, but there is a really high risk of hematoma, and the blood will be pooling inside here, so it can be a hidden hematoma. So in postpartum, the woman can have blood loss, but you wouldn't know because it's pooling here. So if you have a patient with a pudendal nerve block, you need to check for that hematoma. It can gather like half a liter of blood. And so let's talk about the difference between an epidural versus a spinal block. So the epidural goes in the outside dural space, and the numbing is only from the umbilicus to the thigh. This is something we use with vaginal deliveries, versus a spinal. We do it into the intrathecal space right here, and they're numb all the way from the nipple to their feet. And this would be done with C-sections. So we're going to inject. It doesn't necessarily have to be this, but this is what they most likely use with a morphine or fentanyl. They're going to use anesthetic and analgesia into that epidural space, not the intrathecal space. It's a small catheter that's passed, and it stays there throughout labor and birth. This slows the labor process as well, so they need to be dilated to at least 4 centimeters. They'll lose that bearing down reflex, and a very, very common side effect of an epidural is this maternal hypotension. So we always give an IV bolus before we give an epidural. This can cause respiratory depression. So this is what the epidural looks like. We want the mom to be sitting on the bed or lying down, and they're going to be in fetal position, so they're going to have their back rounded. And you as the nurse, you're going to stand right here and keep their shoulders rounded and keep them kind of focused on you while this is happening from the anesthesiologist or the nurse and the anesthetist. Versus a spinal block. This is used with C-sections, like I said, still causes maternal hypotension. It can also, though, cause maternal headache because there could be leakage into the cerebrospinal fluid, so that's something you need to be aware of in the postpartum period. It can also cause bladder and uterine atony, and remember, anytime there's uterine atony, or the uterine is not nicely constricted, then there's risk for bleeding, postpartum hemorrhage. And then if there is an emergency, we don't have time to get an epidural, we'll do general anesthesia. This is just like any other kind of surgery. We'll hopefully give them antacids to neutralize gastric acidity. It can cause problems, though, for the fetus and lead to postpartum hemorrhage as well, though. So there's risks with general anesthesia. So let's now talk about some different obstetrical procedures that we can do to implement or aid in the labor and delivery process. So there are different amniotic fluid volumes. This is what we check, remember, in the ultrasound. And if there is polyhydramnios, or a fluid volume greater than normal, greater than 2,000 milliliters, we look for some congenital causes. This is not always the case. Sometimes it's idiopathic, but with polyhydramnios, you want to be really aware of where that cord is to see if there's a risk of cord prolapse. There's also oligohydramnios. That is a fluid volume that is less than normal, and this is caused by maternal hypertension, gestational diabetes, and possibly congenital anomalies. So when we talk about dystocia, this just means dysfunctional labor, or the labor is slowing and stopping and not progressing as it should. It can be caused by any problems within the 5 P's of labor, but it's usually caused by hypotonic contractions or hypertonic contractions. So hypotonic are contractions that are slowing in frequency and intensity, and hypertonic means that there's not that good period of relaxation between those two. But dystocia is usually when you will have to use things like the vacuum, forceps, or maybe possibly do a C-section delivery, because the baby is just not, it's not happening, and the baby might not be able to tolerate that dystocia. Precipitous labor lasts for less than 3 hours, very, very quickly. There is a high risk for women that have precipitous labor to have postpartum hemorrhage afterwards. So when the baby is breached, before they decide to do a C-section, they'll try to do what's called an external version, and this is done under the ultrasound guidance. We'll give tocolytics to relax that smooth muscle, and so there is a risk of some trauma or bleeding, so we'll give RhoGAM also. And we're going to relax that uterus so we can manipulate the baby and just kind of turn that baby. And it's exactly like you see on this picture where the provider is turning that baby and flipping that baby to being head down. So there are risks, as you can see with it, and a lot of times the babies like where they are, so they'll flip right back. But that's at least what they'll try before they give up and do a C-section. This is the Bishop score. This is how we evaluate whether or not we should begin an induction, or whether or not labor will likely begin spontaneous, and whether or not an induction would be successful at this point. So it's kind of like the APGAR score, and we're just taking the position of the cervix, the consistency, effacement, dilation, and then station of the baby, and we're looking to, and we're just scoring all of these, and then we're going to take a score, and the score really kind of depends on the care that we're going to give. You don't need to know the scores, just know that the Bishop score is used to see the cervical, whether or not the cervix is ready for labor to begin. So if we get a Bishop score where we know she's not going to go into labor on her own, we want to maybe possibly do an induction. A lot of times they'll do what's called cervical ripening. They can do it either mechanically or physically or pharmacologically by giving prostaglandin E. So what we're doing when we give prostaglandin E is we're trying to ripen that, or soften and efface that cervix. We could do it with a balloon catheter. This is just filled with fluid, and we can open it up a little at a time, and it supposedly stimulates prostaglandin release. So when you open up that cervix manually, it's going to stimulate those prostaglandins and put that woman into labor. These right here are just kind of like sponges. They absorb the fluid around the tissue and get larger as they absorb and open up and dilate that cervix. We'll usually have them come in the night before, and then we'll do the induction in the morning, so they'll have these cervical ripening agents overnight. If we, in the provider's office, they can do what's called stripping the membranes. If they don't think that the mom is going to go into labor on her own, they'll do this to stimulate labor. They take their finger right here and just kind of release, kind of take the amniotic sac and kind of release it from being attached to the bottom part of the uterus. And it's supposed to stimulate the release of prostaglandins and oxytocin. And I've heard it's really painful, and studies have shown that stripping the membranes is not as effective as it was thought to believe. So it really has not been shown to really put a woman into labor. So with an induction, there are two parts to an induction. We're going to break the water or rupture the membranes, and we're going to give oxytocin. So oxytocin is a drug. There's a lot of litigation surrounding oxytocin, so it's something you need to be really careful when you are using it. We're trying to obtain a contraction pattern of at least 2 to 3 minutes apart, coming every 2 to 3 minutes, and then they're lasting 60 to 90 seconds. Remember, that is the great contraction pattern we're looking for. Before we start any oxytocin, we're going to make sure there's continuous fetal heart monitoring, and we're going to get baseline to make sure that that baby is doing okay with the use of oxytocin. If you see any hypo or hypertonic uterine activity, we're going to discontinue, and we're going to piggyback it just like we did with magnesium sulfate, so that when it is stopped, it is truly stopped. So it's not going in the main line, it's going into the furthest line you can, or the closest line you can get to the patient. And then if we see the oxytocin causing adverse effects, we can give a tocolytic, which will reverse the effects of oxytocin, or just turn it off. And usually just turning it off really is what helps kind of resolve those issues that you see with oxytocin. And then the second part of the induction is amniotomy. This is when you take an amni hook, it's kind of like a crochet hook, and you artificially break the membranes. And we want to make, and this will make the contractions a lot stronger. but there's a risk of prolapsed cords. We're going to check that to make sure fetal heart is okay, and we're going to evaluate those amniotic fluids. Okay, I got to stop now and start again in a minute.